Good morning, everyone. I'm Dr. Nikitha. Today's class is about varicose veins management. It's a continuation of the previous class about varicose veins. So, in the previous, I've seen a brief about pathophysiology of varicose veins. What are the veins involved? Superficial, deep, and the perforator veins. The symptoms, the classification, CEAP classification, clinical assessment, and radiological assessment. So, in this class today, we are going to see about management of the varicose veins. It's either by conservative, operative, or endovenous, which includes thermal or chemical. So in conservative management, what we generally advise the patient is compression and elevation of limb. In compression, it can be used in all stages of varicose veins. Generally, the material used is cotton or nylon. Day to day, we see nylon being used. It is graded into three classes, first, second, and third, with increasing order of pressures. Yes, sir. So class 1, it's less than 20 mm Hg, and class 2 being 20 to 30, and greater than 30 is class 3. So depending upon the level of varicose veins, we advise the patient the graded compressed stockings, and there are also intermittent type of compression stockings.
What do you use for embolic recurrence? What is the
So 25 to 35 it's mentioned, sir.
so class 2.
Class 2.
Should we apply for RTL?
No, sir. That's a contraindication, sir. Intravenous.
What will you do?
We apply TED stocking, sir, or intravenous, sir.
It's a peripheral artery.
Intravenous anticoagulants we advise, sir, comparing or
No molecular.
yes.
And then you use the
Stockings.
during surgery, no, not stockings. You can't use stockings because it's for the last one. During surgery, what do you use?
Yeah.
Anything?
For intermittent compression, sir. Floatron. Yes. Yes, sir. If there are spider veins or reticular veins and just generalized edema is present, then we advise for grade 1 compression stockings. So it's also used post-intervention in post-sclerotherapy and post-operative cases, and post-endovenous ablation. We advise the patient to use the compression stocking.
How long do you use?
1 week, sir.
After surgery, how long do you use after the endovenous?
Sir, after endovenous procedure, it is advised to use for 1 week, sir, and immediate mobilization. In post-operative cases, 2 to 6 weeks they have advised, depending upon the recovery, sir.
3 months. You use the great bandage for the first week. After that, you use stockings every day for 3 months. After 3 months.
Audio is not clear, yeah.
Sir,
Audio is not clear.
yes. So side effects of compression, there could be drying, scaling, the allergic to material which is being used. So as the patient is wearing the stockings and he do not take the proper care of the certain leg. So we should properly advise skin care like moisturizing and proper hygiene. We should advise him to wear throughout the day or when he is moving ambulatory compression, and when he is lying down or during the night, it's advised to remove the stocking. So venotonic drugs are given along with compression, so it improves the action. If the drugs are given only without any compression, there is been reported not significant improvement. So we should inform the patient that the drugs are effective only after 2 to 4 weeks. There will be any immediate effect. So most of the drugs which are being used are plant extracts. They are mainly concerned with tonicity and decreased permeability to decrease the edema. So, diosmin, flavanol extract, sir, microfilter flavanol extract. Most probably what we are using is DAP1. This is of little significance, so I last class 100 mg, sir. 100 mg.
It's very, you can't take things lightly like this. You should put it up, whether they are useful or not. When you are talking about varicose, medical management, drugs, the list of all the drugs that are used, the dosage. People look at some studies are shown what is the percentage of effectiveness, 30%, whatever. You can't just say, not see, whenever you do a class, that's very comprehensive. So everything about this people management.
Physiotherapy is also recommended in few refractive cases in which post-operative and the post-conservative management there is no improvement. So manual lymphatic drainage is done. It's basically by massaging the edematous leg. So the invasive treatments, they're either open or endovenous. So in both the cases, what we use is tumescent local anesthesia. So it is given around the vein with USG guided approach. So the composition includes lidocaine, epinephrine, and the sodium bicarbonate. Around 250 to 500 ml of solution is given around the vein. These are also very dilute solutions. So in open operations, we concentrate on the removal and if they trophic disorder ulcers, we go for shape treatment as shown in the picture. So the removal of the vein is mainly focused on primary reflux source. Indications of open operation supplements with varicose veins, accessory veins, recurrent varicose veins, if they have any angiodysplasia or venous malformations, and superficial vein thrombosis, ascending varicoceles and varicose bleeding. These are the indications. The contraindications for open surgery are absolute ones are acute thrombosis of deep vein and peripheral artery disease, which is stage 3, and known case of pregnancy and more. And related contraindications are stage 2 peripheral artery disease and serious disturbance in hemostasis, severe lymphedema, and very severe generalized disease, which is greater than the AS4. So, vein removal, it is basically done with clear mapping of the primary sources of reflux and selectively removing only the incompetent sections, not the whole vein. It is practiced right now. So the procedure followed is flush ligation, which is a complete removal of the vein along with the tributaries, and near the junction where the superficial vein joins the deep vein, the vein is ligated close to the deep vein, and the tributaries which are of the superficial vein or the varicose vein are also dissected. Varicose vein. This is flush ligation or prostatectomy. As you can see, all the tributaries are also being separated. Then they will be removed along with this.
And after we do foundation, they were to ensure that all the facilities that enter the sickness rate before the joins the community, we identify to navigate the branches, and then we like once we get the thermal intervention, And we said we use the non-absorbing material. And then what we will do, we can strip the surface vein after the time. This we don't need. So that is then the advantage of that will be that we also take care of the motional media and activities. Right.
So for perforated incompetency, or if there are only perforated incompetency, then direct epiphyseal or subfacial interruption is done. So only the perforators are removed in this case, like getting the superficial and deep veins. So stripping.
So ultrasound, what we call the epiphyseal or the
So
ultrasound in the mark. What do you like it?
sir, depending upon which is being incompetent, sir.
You enter the patient like
Yes, sir, that is both are there, sir. Like subfacial interruption. They said that there are two procedures. So if it is incompetent in epiphyseal plane, only epiphyseal is interrupted. I mean, ligated and separated.
who knows the
Ultrasound cortex.
exactly different. See the veins that are dilated, entering, what is the definition of perforator?
So, connecting veins between the superficial and the deep veins through the fascia and
It perforates through the fascia. So what do they mean by epiphyseal facial ligation is just that is entering the fascia, you are able to see them to ligate it there. The majority of the what we call the perforators is you have to do the subfacial ligation. That is, you go below the fascia and then over the junction and ligate them. What can be done either by open method or what is called subs.
so after ligation, stripping can be done by many methods. So the picture shows the invagination method, where the probe is passed all along the vein and it's ligated at the tip and it's pulled inside. So the vein invaginates and is removed. And this is a cryoligation method. The phlebectomy is a procedure in which only the this is part of the limb what is removed, is pulled out and ligated on the both ends and replacing the stumps back into the and the stripping is almost always done proximal to distal and it is advised to confirm by post-operative duplex scan. So the complications during the open surgery are intraoperatively the bleeding, nerve damage, and injury to lymph vessels and injury to large vessels. Post-operatively, there is secondary bleeding and hematoma, wound infection, or pigment disturbances in the area, and lymphatic fistula, cyst formation or edema, necrosis of the operated region, spinal scar, compartment syndrome. Recurrence in open surgeries is less than 5%. If the patient is followed to 5 to 10 years. The cause of the recurrence is leaving a stump or grades of an SV and failure to the closure, failure to close the reflex, and neovascularization is one of the cause.
Yes, sir, go back. If the recurrence rate 5%, it is 5%.
Next 10 years, 5 to 10%.
Okay, why do you strip the can just ligate and move?
You're doing all of the things.
But post-operatively, whatever the patient is saying, this is the same deformity, no, sir. Cosmetically,
See, yeah, you're right. Basically, the dilated tortuous and, varicose veins will remain, we don't stay. So you have expected the unrisked cosmetic. More importantly, if you leave just ligate the subcutaneous direction or subcutaneous direction, it can still then cause the posteromedial and anterolateral and other branches and the perforations will be there, will then feed, then continue the varicose vein recurrence happen. So that is why the older method was to strip the vein up to the just below the knee. You don't go, previously they used to strip all the way up to the ankle. But that is what is the reason why they stopped doing that?
nerve injury is more common, sir.
That was not injury. So generally you say up to the thigh stripping, so you strip up just below the knee, and then they used to do what is called as avulsions. So you use either fine artery forceps or a hook to mark the varicose veins, and then you pick up the vein and then strip it on either side for as long as you can. So basically, it is actually one, removing the dilated and diseased vein, and two, it will stop the communication with the perforate. So that was the purpose. But that is all now old method. I don't think anybody still do that. So that you should know, all of you should know that during local procedure, whether
We go open procedure to that, again is to split the vein, right, flush ligation, split the vein, and below knee, whatever superficial veins are there, like neck and hook technique is used, so that it can incision, they will go ahead and take out all the superficial veins possible.
you have a special knife, very small knife, you would think, and you just make a small hole, and then you have a hook. So you basically hook the vein, and then you put a mastic or artery, and then you have pulled. So you get a segment of it coming out, so then you put a website, then you can just apply pressure, it's not weak. The advantage of that is one, you are getting this and disease, or the dilated veins between cosmetic will also look bad. And second, most of them will then lead on some perforation. So there are totally sometimes even up to 100 perforators may be present. So you are basically disrupting the communication with the perforator, which is one of the reasons why you get recurrence. So basically, what you do is strip up to just below the knee, and then do the avulsions of all the dilated veins that are. And when it comes to certain opportunity or dilation, see the thing is all of these remember, when you are assessing varicose veins, you have to, especially for certain opportunity junction, you will have to get your radiologist to mark the certain opportunity junction, because circumfemoral junction is constant, certain opportunity is not. And you don't know where it is, and you make an incision, you will be lost. You have to mark it where exactly and make an incision over there. And then you will see the short circular vein entering the popliteal vein, and then you do the flush ligation. Again, what is the nerve that can be damaged by doing that? So this much I think about the basically you have to do it in a scientific manner, in a very this one is I think the indications will be extremely big, very bad varicose veins with complications like venous ulcer and things like that. Generally now, I think they are progressing in such a way that even the indication for endovenous treatment, whether it's laser or other therapy or whatever, is expanding, and also the long-term results.
But I think for you people, it is important to know the diameter of the vein, and we will go ahead with the surgical incision. So whenever the GSV is more than 12 mm for the size, I'm talking about the diameter, then you have to, then that is one of the indications to go ahead for the straight away surgical or very superficial. It is just below the skin. Where we are going to even luminescence is not possible. When it is such flush towards the skin, then we have to go ahead with the surgical. The skin burn can. Should not do, because skin burn is very important.
Pawan, what is the principle of tumescent anesthesia? He said about tumescent anesthesia.
So, surrounding issues.
Where do they use tumescent anesthesia? Nikitha.
Sir, it's injected all around the vein, sir.
Yes,
It's
I
a
agree.
hydrosection and also local anesthesia.
Right. For what purpose are they using tumescent? That is not the treatment, it's only anesthesia. So what do they use it for? Which I'm asking, you see, that if you are going to operate on inguinal hernia, you are describing the spinal anesthesia. After that, you have to describe the procedure. No?
Yes, sir.
Similarly, what do you use it for? You have given tumescent anesthesia. Is that the treatment?
No, sir.
Then what do you use it for?
We use it for ablation.
This is what I wanted to know. All the endoluminal procedures, right? So all the endoluminal procedures you use it tumescent anesthesia. Why do you need to use it?
Because it generates more amount of heat.
Okay, so you want to reduce the collateral damage. Want to reduce damage to the dissection, and also because there is a lot of liquid there, that will take the heat. The tissues will not get burned. Now, whatever else.
What is the maximum dose you can do?
You have written there, no? Or you said 250 ml.
Yes, 250 to 500 ml is
250 per leg.
250 per leg.
per leg.
No, you are.
They say 3 milligram. So 3 milligram.
50 ml of saline.
Diluted.
500 ml of saline. In that, whatever dose they have written, that.
Lignocaine and adrenaline.
Is 30 ml of lignocaine, 0.5, 0.25 or 0.5%, and 1 ml of soda vaibhav. 500 ml.
You're almost diluted.
Yeah,
Right. Okay.
So this lasers.
Yeah, we'll talk about that. So, because now we have come to I think the recurrence rates. See, the commonest cause for recurrence is the non-identification of the branches of the sacropemoral junction. That is singularly the most important. I have seen, consultant surgeons and vascular surgeons do this, and showing. So the thing is, actually, the sacropemoral junction, classically described as 3.5 or 3.75 centimeters below the, mid-inguinal point, whatever, but it's probably much higher than that. So the vascular surgeons in England would make the incision above the groin crease, because the branches that come from above, circumflex iliac and all those things, would come from above. You will easily miss it. And you have to identify the critiform fascia, you have to identify the femoral vein on either side. So till you have done that, you will never be able to ensure that all the branches are ready. So this is very critical. So you have to ensure all that is singularly the most important cause for recurrence. Then there are unnamed branches which may be So that is why the recurrences are between 5 and 10%. 5% in good centers where they do these surgeries on a regular basis. In 10% maybe in failed places where they do it occasionally. So expertise is very important. Okay. Right, carry on. Any questions on open surgery so far? Have you all understood what to be done, what needs to be done? Everybody? Okay. Because in the exam, that is what they are going to ask. Of course, they will ask you about the endovenous also.
Sir, I just have one doubt, sir.
Hmm.
So we are dissecting here and ligating it, and we are introducing from here, sir. But what about all the tributaries in between, sir? So are we going to ligate them or?
No. See, the thing is, see the posteromedial and anterolateral branches usually join the saphenous vein. Okay, so basically, if you're removing the vein itself, the tributaries don't matter there because they will also be disrupted. So the advantage of that is once you strip, you basically you have to do what you have to do is if you have observed the surgery, then what is important is you keep everything ready. Okay. Then you basically ligate the saphenofemoral junction. Then you pass the stripper. Don't strip at that time. Keep everything ready. Then finish your avulsions. Okay. Then basically lift the leg up and then start applying the crepe bandage. As you are applying, then you and also the lower aspect where the stripper is coming out. So basically, you have to ensure that even the suturing of that is almost ready. So as soon as you strip, you apply the compression bandage. So there will be some amount of bleeding. You can't help it, but you can avoid major amount of hematoma and bleeding into the percutaneous tissue. Okay, so that is how you do it. So that way, keep the leg elevated and then apply the compression bandage and then finish the stripping. Then close the upper part of the wound. That is the groin wound, groin incision.
So to prevent the recurrence, what are the measures you can take? Your exact mapping of the recurrent sources and the use of non-adversarial sutures, different marker, brace and stump, and close the sinus opening. Recurrence can be diagnosed clinically or radiologically. Even in the recurrence varicose, the same treatment as primary varicose is done. But the complications are higher in the primary varicose. So endovenous techniques, it could be either thermal ablation or chemical ablation. In thermal, it's either under steam or laser. So steam, as you can see, the tip of the laser is introduced into the vein through a 16 or 18 gauge needle. Later, fluorescent anesthesia is given around the vein, USD guided. Then from 2 centimeters from the saphenofemoral junction, the tip is activated. So steam of 120 degrees is introduced into the vein, which causes the closure of vein. As you can see, when the steam is introduced, it generates a lot amount of heat, which causes fibrosis of the varicose vein. It is done in multiple levels. Once if we finish this area, we have to slowly pull back the catheter and apply the steam again. So it is done like 3 to 4 times all along the vein, depending upon the effectiveness of the catheter. So
laser doesn't generate steam.
these are thermal, but both are work on base of heat only.
This steam therapy is completely different. Then you have to introduce only steam. There is one more method that we have. Those are the newer things where we don't have to give the humus. We just have to insert the steam, and through that we all will get disturbed. Endovenous venular endo layer of the wall will get disturbed, and then it gets collapsed. Laser definitely it works on the thermal, but it works in a different phenomena on which they will generate the heat and lines the RBCs. After lysing the RBCs, there will be let's say aggregation, and also at the same time there is a disruption of the water. That's how it gets.
So how do you use this? Why not?
There are newer techniques. That insertion of the steel, that catheter, we don't have that. Only one or two places they have that. So it is same phenomenon. There is nothing different. We use the laser.
The heat will cause problems with protein and
Coagulation, protein disruption. Only the inner layer of the
endothelium is the
endothelium is that.
So, in case of laser ablation, 810 to 1940 nanometers of waves are used. And the laser energy for the thermal dynamics of the venous wall, as sir has explained. It lyses the RBC and the inner layer of the vein is damaged, which causes the closure of the vein. Collagen denaturation occurs, which leads to venous shriveling and finally closure of the varicose vein.
What are the lasers you use? What lasers you use?
So I actually tried to look into it, but I got only the wavelength, sir. Not the specific laser.
See, for example, in ophthalmology, what they use?
Neodymium.
NDR laser, neodymium, yttrium, argon, garnet. That is why it's called NDR. Neodymium, yttrium,
Yttrium organs.
argon, and garnet. NDR. What do they use here?
Couldn't get it, sir.
Anybody? That's the homework. Huh? Holmium. So you need to go and find out what laser.
We use MM of waves is 1470 in our hospital.
Okay.
So, sir, please explain to them how you do it. So you identify, using Doppler, you identify the base.
Basically, we require 5 to 7 hertz, 5 to 8 hertz vascular probe. They will definitely ask you this question if the question goes on intravenous laser activity. We will first map the way anatomical position of the we will see. Though we have the scan on the radiologist, but many times even radiologists will be on a, we are the surgeon and we have to do a pakka job, so we have to see the way for sure where it is between, whether how many branches are there, how many tributaries are there, whether staphylopopliteal junction is also incompetence or not. All that things. Once we see that, below the great staphanous vein, we will identify and we will puncture the vein, and we will insert a 6-French sheet, and we will take an access of this needs to be 6-French sheet below it. After that, we will pass a laser fiber, and we will keep the tip of the laser fiber 2 centimeters distal to saphenofemoral junction.
Why do they not go closer?
Femoral vein.
You don't want to cause DVT, you don't want to cause damage to the femoral vein. That's why you don't want to go very close. The open method, you are not handling the femoral vein. You are only handling the saphenofemoral junction. But here, the heat may dissipate and cause problem. Yeah, 2 centimeters.
Even if we keep the endovenous laser tip 2 centimeters distal, after procedure, if you see up to the SFJ, the vein will get fibrosed or it will become non-collapsing. So once we keep the tip, then we will do the conditions anesthesia as you have told. Very venular area. We will again with the help of probe, we will puncture on the both side of the vein, right and left side, and we will inject that conditions anesthesia so that a complete vein should get surrounded by the anesthetic liquid all along the leg, all along the leg, up to below knee. Once we confirm that, then again we check the tip of the endogenous laser fiber. After checking everything, then we will do the firing of the laser. And as we come down, we keep on checking with the probe whether we have done a perfect job or not. What we will see there, whether vein is still collapsible or not. If it is still collapsible, then we have to do it again.
There is no time, no time.
The 1 centimeter to 1.5 centimeter, it depends upon the we have to pull it out, and we will make that laser fiber in a pulsatile mode, so that every 4 seconds or let's say 5 seconds after that much of amount of energy is deployed, then that automatic beep will come. So that okay, that amount of energy is deployed within the 1.5 seconds. And after that, we are going to pull it back. It is a slow procedure. It takes around 15 to 20 minutes to ablate a single vein, which is properly. Around 70 joules energy we have to deploy in that area in that amount of time. That setting. If you come to the OT, then I can tell you again the person.
Next time when there is, will all of you go and see. Because
Yeah,
they will ask,
once we should see.
and all of you, they will ask you, not for exams, it is for learning, very important for you to know what is being done.
Next is the radio frequency ablation. The same mechanism appears here. Heat is generated using the radio frequency waves, and 120 degrees in segmental radio frequency and 60 to 100 in bipolar. As there is high temperature, this is a prepared technique. It will be done with the 7 centimeter generally it is done with 7 centimeter segments. Bipolar, it takes a longer time. Normal complications of endogenous techniques are ecchymosis, nerve damage, burns, post-ablation thromboembolism, deep vein thrombosis, embolism, and paraspecias. So, chemical ablation techniques. The most commonly done is sclerotherapy, in which polyphenol is used as a sclerosing agent. So, it's even in the all stages of varicose veins, it could be used. Periulcerous veins, spiral veins, and reticular veins. These are the most common things which we do not do surgery for, and the sclerotherapy is applied there. So, it was a university guided procedure. We introduce the needle into the catheter into the varicose vein, and we fire the sclerosing agent into the vein. And as you can see, the vein is fuller. Contraindications of sclerosing agent are if the patient is allergic to the specific agent, and acute venous embolism, local infection of the vein. So, home therapy is also done with the same procedure and same principle. But if the right to left shunt is contraindication for the home sclerotherapy. So, the relative contraindications of sclerotherapy are pregnancy, lactation, peripheral vascular disease, poor general health of the patient, risk of embolism, and if the patient is bedridden. In the case of home sclerotherapy, neurological disorders like migraine, we do not go for home therapy. So if the patient after 30 versus the patient has told it is so this is the newer technique, which is mechanochemical, in which the catheter has a rotator at the tip. So it can be done without use of any anesthesia. When the catheter is introduced into the varicose vein, it releases a chemical agent, which is almost similar to sclerosing agent, and the rotator is movement of the tip of catheter is activated. So it causes damage of the inner layer wall, varicose veins. The vein glue, like cyanoacrylate glue, is also used in few cases now, still under study. So, as we said, pregnancy is contraindication for all the things, for all the treatment management. So, we generally go for conservative management in the case of pregnancy, and the chances are 2.69 times higher post pregnancy. So, it could have developed varicose veins. And the patient has 3 or more pregnancies, the chances of varicose veins are very high.
Long-term recurrence is there. It is after comparison, what they have told that it is not as significant, or it is there is no significance whether you do the open surgeries or laser surgery. So recurrence is almost quite good. See, you go ahead with the proper laser procedure or
Then why lasers are after population or being fibros?
there will be always see our leg is always under pressure of the body of our body. So whatever amount of superficial veins it will keep on developing.
So another veins will be.
What we are evaluating is the great saphenous vein and short saphenous vein. You can't evaluate all the 1,000 veins which are there among the in the legs. Invariable number of the perforated. Okay, dot and other type of perforator that is named perforators which will be found in that area. So there are a lot of million perforators. In the lateral aspect also there is a perforator posterior and anterior. So those means develop over the period of the time if the patient is not using stocking. It's not necessary that GST will only come and they will form a recurrence of the may, but there are unnamed lot of veins which when we are operated that time it might have been normal. But over the period of 10 years, that might be dilated.
Underlying pathology, what caused varicose veins has not been addressed. All we are addressing is the end result, which is the varicose veins. So what is that causes the, for example, valvular disturbances or whatever. See, what if there is the absence of valves or valvular, this one, the abnormality or weakness or whatever, and that will persist. So, as Sir said, that will all of those factors will be in play. So, for lifestyle changes, you may have to advise patients who are standing and things, you have to tell them, you have to change your position. For example, you can't tell soldiers or security personnel to change. They can't sit around. They have to be standing. So you can't help this. Some of the things are, so you can use compression stockings and all those things. Most of it is to try and minimize it. But the underlying problem is not fully addressed. Complicated recurrences will happen.
It's very difficult to address complete problem. For varicose veins also, if we are doing the laser, we will always tell our patient that we are going to control your varicose. We are not going to vanish it. It is not possible to vanish, and whenever the patient will ask us the question about the recurrence, actually that's the first question. They will come with so much things in their mind and they will ask that how much is the recurrence. We tell what the book says, but at the same time we tell that we are going to control it. Even if we are doing this procedure, still it will get control up to 95%. 5% even I am already having that.
So,
the laser, what they say is that pain percentage is on the higher side post operative. Radio frequency ablation that also decreases. But again, that is not significant. There is this significant amount of pain.
Chances of recurrence after sclerotherapy.
30%. 70% it drops. 30%.
Okay.
Only if you use this curve.
You can use in a fully dilated varicose veins.
Maybe also express sign on
Here we use this kind of. We are explaining to the patient properly and think it like you.
Different in our radio frequency ablation and laser. What I have studied is we can't use in the perforator
Perforator, because in the laser there are newer laser has come, small laser, the big fiber. very small fiber also have found UPA where we can puncture the perforator also. In RFA that technique has not come yet. So that's why, but I'm sure in 1 or 2 years it will come.
These are also not, RF is not possible in more dilated and arches.
Possible. But yeah, what you are given in the book that you should keep in mind. Practical aspect and surgical aspect is not totally different, but yeah, there is a difference. With the help of dilated veins also we have done the RF and steps. Right? The thrombus veins.
It's already.
That is
Stripped.
no. Which thrombus?
Yes, sir. Yes.
Yes. How much thrombus is? More than 5 centimeter or whole is superficial thrombophlebitis you are thinking?
No, just like there will be torches and thrombus will can be from sometimes.
So that's what, that is the superficial.
Yes, sir, that is, yeah.
So we can, in superficial thrombophlebitis, can be doing it. When we have even if there is a superficial thrombophlebitis, what are the
Lipodermal. Surrounding.
superficial thrombophlebitis in acute condition? In acute condition, there are very less indications, where still we have to address the superficial thrombophlebitic vein in a surgical manner. There are certain indications for that. What are the indications for a procedure on superficial thrombophlebitic vein? If it is infected, if it is causing severe pain, that patient is not able to lie or sit, it is totally inflamed. That is one two indicator. And if we want to prevent it to occur, to progress it towards the DD, let's say if it is more than 10 centimeters, there is a thrombus, then there is a chance that it may progress and have a DD. In that, we have to budget the, let's say, in acute condition, never that is. First, that's when you will get caught. You are the example, you are doing. Sorry.
Please do 3 years ago. So we have not done much varicose.
Yeah, inside.
So especially lasers to what is lacking in this presentation? That's why I asked her in the beginning, which she has not done. She has not put up any, see, you at postgraduate level, textbook learning is not sufficient. That's why sir kept on telling what is given in textbook and what is in the thing, it's different. I will keep telling you textbooks are 5 years old. Whatever information, it's not their fault. What is authentic and what is proven, they put it up. But science advances beyond that. So she has not put up any papers, any comparison between all of this. There are lots of papers available. I think at your level you should have done that. So I'm very disappointed that you have not done it. Put up good papers now in the all of you. Okay, read up and put it up. Okay. Thank you. Thanks. Thank you so much.
Television kita.